have to
patients.
say, I used to think CLL and CML, I like the analogy. In my brain, I always think in CML you have this BCR-ABL,
Sure.
you have the protein.
Right.
In CLL, while we identified some of these genomic aberrations, we never really knew exactly the pathognomonic feature for CLL.
Right. So yeah, I mean, it's I think it's the reason I say that. So CML is that I have been asked that before, and people say that, right? But you're absolutely correct. There is 922, one translocation. Here, there is no unifying translocation or unifying abnormality. It's 17p, 11q, 13q, lots of different mutations. So it's not one disease. And in fact, as you well know, people say mutated IGHV CLL and unmutated IGHV CLL are totally different beasts, totally different diseases sometimes. So it's a multitude of different genomic aberrations, but at the end of the day, we know most of our current targeted therapies work irrespective of the genetic aberrations. They work really well across the board. So I think that is a one big, I think, unmet medical need, I think, in the context of CLL. The other one will be a Richter's transformation, which again is a more aggressive transformation of CLL. It's a DLBCL transformation of CLL, which occurs in maybe 4 to 5% of patients with CLL, but that is something of a very unmet medical need truly. The outcomes we have with chemotherapy, with venetoclax, with target therapies, with clinical trials, still we are talking about less than 1 year survival for these patients, unless they can get to transplant, which again, for majority of these patients gives us their age, commodities, lack of remission of their Richters, they're not able to get to the transplant.
So you guys have trials for these patients' Richters right now?
So we have several trials right now at MD Anderson. We are investigating pirtobrutinib in combination with venetoclax and obinutuzumab for Richters. We're evaluating venetoclax obinutuzumab with a checkpoint inhibitor, atezolizumab, PD-L1 checkpoint inhibitor in Richters. We have some CAR-T trials, some novel CAR-T strategies in Richters right now, and also CD20 bispecifics. So we have a trial right now. So I think multiple avenues of trials right now. So we'll have to see how these pan out.
These are really, you hit the nail on the head. When I was seeing patients, these are so tough to treat. You do everything possible, and if you find something for Richters, will be great. So double refractory Richters, what else?
I think those are the two major subsets. I think those are finer unanswered questions. So those are so questions. Okay, what is the role for MRD? What is the sensitivity of MRD I should look? 10 to the power minus 4, 10 to the power minus 6. Should I use pirtobrutinib or a non-covalent BTK inhibitor before a covalent BTK inhibitor? Should I use pirtobrutinib in the frontline setting? What should be the sequencing approach? Should I do ven-based therapy first or a BTK therapy first? So I think those are questions for which I think we don't have really good data-driven answers. I think everyone's practice is a bit different, and some of the clinical trials are trying to address those questions. But I think those are again lots of you can have a long talk just on each of these specific subjects. But I think yes, you're correct. I think some of these MRD sequencing strategies are still up in the air what their role is in the context of CLL.
Well, I appreciate everything you're doing in CLL. Really, these are important, and hopefully next time we meet, we're going to have few more answered questions.
We'll look forward to that.
Great to see you.
Always good seeing you, Chadi. Take care.